So a very good afternoon and welcome to this webinar, which today is going to focus on the work that the Infection Prevention and Control team at Betsy Cadwallader University and Staffordshire University's Forensic Science Department have been involved in, looking at the use of forensic light source for the detection of invisible substances. I'm Paul Anthony. I'm the conference producer here at Knowlex, where we disseminate healthcare information via our training modules, our conferences, social media, and of course, as you can see, via our webinars. Very shortly, I'm going to bring in Paul Clark. He's a visiting fellow at Staffordshire University, and Dr. Sarah Fieldhouse, who's Associate Professor of Forensic Science at the School of Justice, Security and Sustainability at Staffordshire University. But first of all, we've got to run through a few housekeeping rules. First, can I please ask that you don't share any of the presentation slides from today on social media, and please don't share any screen grabs of the presentation slides either with anybody else. There will be a PDF version of the slides available to download after the webinar is finished, and we do have your emails, so we'll email you directly when that PDF version of the slides are available on the website. During the webinar, you will be able to ask questions by typing them into the chat box, which you'll find on the right hand side of your screen. We will try and answer all your questions during the session, but if we don't manage to do that, then our speakers will answer them by email after the webinar is finished. And also, the webinar will be recorded. We understand that you do have jobs to do, so if for any reason you've got to leave before the end, you can watch it again at your leisure from tomorrow onwards, and you can also play it to your colleagues if you so wish. So let's get the webinar underway, and first of all, bring in Paul.
Thank you, Paul, for those really kind words. And can I also thank Knowlex for being the communication lead for this particular piece of research. If we could have the next slide, please, Sarah. I'd just like to spend a couple of minutes before I hand over to Dr. Sarah, who's going to cover the majority of the research presentation. But I just want to kind of give a quick overview of where our journey started. And it started about 18 months ago with a really simple Teams call between Sarah and myself. At that point in time, I was working as the head of facilities management for the Betsy Cadwallader University Health Board. And that particular Teams call asked one question. Could forensic science models be used to support infection prevention? And at that point in time, I said a very loose yes, because I really didn't understand what forensic science was all about and how it could actually be interlinked into infection prevention, which is going to be part of Sarah's presentation very shortly. So as I say, it started about 18 months ago. And we decided, yeah, let's have a go at this. And we spent a period of time working through a design phase. And then we put a bid into the Health in Infection Society, a small bid to see whether we could actually undertake a project to look at the proof of concept of whether forensics could be used to support infection prevention. And from then, we kind of undertook the field work between October of 2022 and February of 2023. And we also had two really good celebration events during that period where we both went to Betsy Cadwallader University Health Board and to Staffordshire University to actually undertake some memorandum of understanding celebrations. The end of that phase really happened in April when we attended the Knowlex IPC conference down in Birmingham, where Sarah and myself presented the findings from that first phase of the project. The main aim for me of that particular project was actually to look at patient safety and how we could support patient safety. And I think just moving on to our next slide, it picks up where our aims of the project really sit. And as I said, it was to identify the feasibility of using forensic science methods to improve outcomes in respect of infection prevention control in healthcare settings. And our vision was to deliver a strength-based research programme in partnership with both forensic and healthcare professionals to allow the invisible to be visible, to support patient safety, as I mentioned, and also to uphold the values of do no harm. And the last point of our aims was to provide continuous improvement in adopting zero tolerance to healthcare associated infections. And I think over the next over the next slides, Sarah is going to actually give a lot of evidence in regards to the project that we undertook, and also kind of some of the findings which we actually kind of collated from that field work, which for me was really exciting, and will lead into the second phase of our project research, which I will pick up at the end once Sarah's actually covered the research program. Okay, can I hand over to you, please, Sarah? Thank you.
Thanks, Paul. Hello, everybody. As Paul's introduced, my name's Sarah Fieldhouse. I'm an Associate Professor of Forensic Science, and I'm based at Staffordshire University. Because I'm based in forensic science, I probably haven't met many of you at all. Obviously, I thank you for taking the time to come to the webinar today and to hear about the research that we've been undertaking. It's been fascinating to work alongside colleagues within infection prevention and control, and certainly I haven't any prior experience, although what I would say is forensic science is an incredibly applied science that has applications within chemistry, biology, and now our exploration into healthcare has been really exciting. So I hope you enjoy learning about our work, and please get in touch with any questions that you've got, or if you'd like to become involved further. My background in forensic science, I mean, I've worked for the last 20 years, and it's generally in the area of fingerprints. So this is about identifying people on the basis of their fingerprints, but also about what fingerprints at crime scenes are made of. So the composition of the residue that you have on your hands and how to visualize this. Now, translating that into infection prevention, we've talked about sources of infection that you can't see and how they might be transferred around. And we know that components within your finger mark residue, for instance, might actually contribute to that sort of transfer. There has been some translational opportunities that we've identified.
Sarah, you've turned your microphone off.
Sorry, everybody. Just giving you some background to the project. We've conducted some work with Mountain Healthcare in 2 sexual assault referral centres. And this is with a company called Coppertree Forensics, who commercially produce light sources to the sector, particularly in forensic science, but are broadening into other areas. And you might be aware of one of their instruments called a sci-fi torch, which we're going to pick up in today's presentation as well. In this particular project, we were looking at detecting sources of contamination within those referral centres, and with a particular emphasis on material that might contain DNA. So there was a patient safety perspective to it, clearly, by keeping those environments clean and safe, but also about identifying material that could pose or may want to be used as forensic evidence. And in order to ensure integrity of those evidential samples, it was about how can we use forensic technology to detect material there. And it was light sources that were used, and it's light sources that we're talking about in the research with Betsy. Okay, so as Paul said, we're looking to see if there's any potential to apply what we've done in forensic science and some of the background work within the sexual assault referral centres to infection prevention and control. So we'll share with you the study that we've undertaken and the results that we've got, which I guess they are in their early stages, but we think that the results that we've obtained to date are giving a really solid foundation for future work. And we're very much building a national team of experts that can really drive this project forward. Before we move into that, just to give you some sort of theoretical basis for it. When we're talking of viewing the invisible, it's about using fluorescence technology, or you can use coloured lights and filters to help improve the contrast in materials that might be present on a surface. I mean, thinking as simply as using a white light if you've got a glass surface and you can see greasy finger marks that are there. That's one way that you can use light to detect material. But some substances, if you shine certain wavelengths of light onto them, they will absorb that light and they'll convert the energy into light of a different colour and of a longer wavelength. And we see this as fluorescence. Now, one thing or a type of forensic evidence, because this technology is widely used in forensic science, one material that will fluoresce is many body fluids. So saliva, semen, vaginal fluid, urine. And so you can see why the process is so widely adopted for forensic methods, because in terms of forensic investigation, you're trying to find material that might be evidentially useful. But looking into infection prevention and taking the citation there from the infection control precautions, so blood and other body fluid secretions or excretions, non-intact skin or mucous membranes, and any equipment or items in the care environment that could have become contaminated. So because of those priority materials, substances, we've obviously talked about whether we could use fluorescence as a way of visualizing these kinds of substances and how it might educate us as to how do we remove them from the environment, for instance? Are there any patterns to where we find them? It's also true that there are many substances that perhaps aren't body fluids, for instance, that also fluoresce. And part of the project is looking about what might they be, and might they be of any interest to IPC, with an emphasis really on patient safety here. Okay, I don't know what your backgrounds are with respect to fluorescence, and I guess this is my comfort zone here. But this slide is giving you some examples of how fluorescence is used in forensic science, and sort of what we're looking for. So on the left-hand side there, you can see some fingerprints, and fingerprints generally, as I've said, you can't see with the naked eye. So they would have a fluorescent substance applied to them, it would react, and then you would use a light source in order to view them. And these light sources typically look like torches. Okay, there is laboratory instrumentation that you can use for this, and the specifications of those instruments clearly vary according to how much light they give out, for instance, and whether they're portable. The central images that you can see there look like a bit of a domino. You've got blood and semen mixed together, and the droplets at the top are showing you what it looks like without the light source, just under white light. And then at the bottom, you can see that you've got a light source applied to it, and you can see that the semen's fluorescing. Blood appears darker simply because it absorbs the light. But what that light source is helping you to do is to detect that there's a mixed sample there. Okay. And then on the right-hand side of the screen, commonly used within document examination, because some inks fluoresce, for instance. So you've got some, obviously the numbers that are there, and then if you look at them on the bottom image, you can see them under infrared light, and you can see that two different inks have been used to construct that document. So moving probably into your comfort zone now. Okay, we're looking at healthcare settings, and the research that we're describing was funded by the Healthcare Infection Society, and it was about taking fluorescence into an NHS hospital and seeing how the results compared to ATP testing for infection monitoring purposes. So it was a pilot study, and and we conducted the work at Chirk Community Hospital. The rooms that we looked at were identical in terms of the type of space, and they were 3 one-bedroom and the adjacent toilet rooms, and all of them were examined once post-patient discharge and following their routine cleaning process. And incidentally, when we went into these rooms, we weren't aware of exactly what IPC would be focusing on. And I think that was a really useful part of the experimental design, because it really mitigated against bias there. So instead of us going in and saying, OK, we're going to look at the 10 high priority areas, actually, we just went and looked at everything within there. And then from that, we were able to work with practitioners to work out actually where the significant value to IPC might be. So what we did in the space is we, first of all, had a look to see what traces of material we could see with the naked eye. OK, so just visual examination there. We then used our light source. So on the right-hand side, you can see an image of a torch called a Sci-Fi torch, cleaning inspection forensic investigation. It is a torch that's been produced for the healthcare sector, but it's very similar in terms of its properties as you'd use in forensic work. So we then looked at all the surfaces available in the room, so the walls, all of the items of furniture in their entirety. So we would, for instance, on the bed, we would take the mattress off and look underneath, looking at both sides, undersides of the table, and to see where we could see traces of fluorescent material. And where we did see traces of fluorescent material, we would take photographs of it. And we would take photographs in control areas as well, actually where we don't get fluorescence. And the point of this is you can only use this technique you can't use it on all surfaces. Not all surfaces will be suitable. So for instance, if the surface is fluorescent itself, you wouldn't be able to use this. But it's obviously important to establish what the potential might be, which is why we looked at everything. We then looked to compare this technique to the existing environmental monitoring process that was used at the Health Board, which was ATP testing, and I'll come on to that in due course. So we turned it into a bit of a crime scene. So you can see we've got numbers on each of the items. OK, so each item got its own number. And then each trace, the fluorescent trace that we saw, got its own marker as well. So we can look at the number of traces that we saw and where we found them as well. And it helped us to document really where everything was, so we could see if there were differences between items. And then when we looked at the repeat items, were there patterns perhaps in the locations of these stains? And what you can see on the fluorescent images are examples of exactly what we found. Now, my understanding is a lot of the assessment that you'll typically carry out to determine if something's clean will be a visual examination. And I absolutely understand that, because you want to remove any visible material that you can see. And clearly today's presentation is about looking at things that you can't see. So we're just giving you some examples here of the kinds of things that we saw without the light source. But then the invisible traces are obviously where you're looking at a surface that has been cleaned and you can't see any of these. So all of the fluorescent material that you see here are traces that you couldn't see without that light source. And bearing in mind that these are post-cleaned. I've touched on this very briefly, that not all surfaces are suitable. So I think if any establishment that was looking to take on this type of technology would have to have a real understanding of when it's effective and when it isn't, and that is largely linked to the type of surface that you've got. Now, fortunately, many of the surfaces that we encountered in the patient rooms were highly suitable. But I just wanted to raise that because it's something that you'd need to consider if you wanted to use this. So this slide here is giving you some idea of actually how often that light source was useful. So all of the green items here are when it's entirely suitable. So if you use that particular light source on these items, you would find that fluorescent traces would stand out really well from them. So encouragingly, a lot of these items are located around your patient space. Those which are unsuitable, it could be that they're reflective, for instance. So there'd be a health and safety consideration to make for using a light source on those particular surfaces. And those which are partially suitable, it could be that they, as it says, they contain a mixture. So a commode, for instance, because you've got the stainless steel reflective parts to it, you probably wouldn't use the light source there. But on the plastic parts to it, it's entirely suitable. Giving you some examples here of how you see traces appear when the surface is suitable. So this is at the top of the mattress, as you can see. And I think what's crucial to note with these results is that the type of stain that you see, they're not uniform. It depends on what they are and how much of it is there as well. You do see a variety of intensities. So some stains which are highly fluorescent and some which aren't, some which cover large surface areas and some which don't. If we're looking at the tabletop here, we did see that there was a difference generally between the traces that we saw on the top of the table and those that we saw on the underside. And unsurprisingly, perhaps, where you've got corners or crevices within an item where you might have debris collecting, you tend to get a lot of fluorescence in those areas. And we know that these are material, well, in most instances, these are materials that haven't been removed during cleaning, because when we did then remove them with the ATP tests, the substances came away. Okay, so apologies if you're already familiar with ATP testing, but ATP testing is an environmental monitoring process that's used in many industries to detect cellular material. And in this situation, it might be used as an indicator of bioburden. In the health board, there were 10 centimetre squared areas of targeted surfaces, for instance, would be sampled, and estimations of ATP in those areas would be used as an indicator of cleanliness. Now, understandably, there are practical issues with swabbing or exhaustively swabbing a space. So you can see why you couldn't use this, in all instances, for example. And clearly there are financial, staff and resource limitations with using ATP testing, in all areas. But when you're using a light source, for instance, light allows you to screen larger areas of whatever it is that you're examining. So there was a potential advantage to using fluorescence there. But given that it was the industry standard, if you like, it was important to see how the fluorescence examination approach compared to the ATP testing. And so I'm just going to give you a flavour of some of the results that we've got in today's presentation. So if we take one item, so I've taken the patient chair. The blue bars are showing you the ATP test data in the fluorescent areas and the control areas. So these are adjacent areas of next to the fluorescence traces and the ATP reading in that area. So the technique is certainly picking up material that is well in excess of the threshold level. So this is the threshold level of the health board that you can see with the green line there. Now, you're perhaps thinking that's unsurprising because you know that you're swabbing a substance in that area. So you're going to, potentially you would get a higher ATP reading. But I think what I would say to that is you can't see this material without that light source. So knowing that you would actually swab in that area is a kind of down to chance, really. So I will look at the later on in the presentation about how much or how many test sites that we had that were actually in excess of those thresholds. But certainly many of the areas that we sampled, we found that there were high ATP test readings. So if we look at priority items, the bed, the chair, sink, toilet, etc., you can see that we've got lots of test sites that are identified on each item, many of which are in excess of the 50 relative light unit threshold that we had. Not all, but that's to us raised the question of, okay, we know there's a substance there and it hasn't given a high ATP test reading, but actually what is it if it doesn't contain ATP? So we have conducted some preliminary work back at the university within the chemistry labs to try and work out actually what those traces might be. And we've had some promising results. Because it's early stage, you're not disclosing what those results are at the moment, but there could be some real potential with this technique here in picking up material that is still of interest, even whether it contains ATP or not. Okay, when you're using this technology, I wish it did, but it does. The differentiation potential between traces that are in excess or less than your threshold level, it isn't going to tell you that. So it's not, for example, the brighter the stain, the more ATPs within it. It's not like that at all, because there are many substances that you'll find within your environment that will inherently fluoresce. What it will tell you is if you've got a surface that has been cleaned and you're still finding material that you could remove, then that area possibly hasn't been cleaned, or it hasn't been cleaned to a standard that has removed whatever that material is. So these are traces that are less than that threshold level, and you can see some of them are still really, really bright. Okay, so to summarize our conclusions to date, a significant proportion of the surfaces that we looked at were suitable for examination. And so the bed frames, the overbed tables, bedside units, mattresses and pillows, toilets, commodes and patient chairs. Now, if we look at the surfaces that they consist of, and then looking at alternative surfaces within the hospital environment, it's suggestive that actually you could use this technology on far more areas if you wanted to. It detected many traces in excess of that 50 relative light unit threshold across the 3 rooms. And just considering that if you're targeting, or sorry, when you're conducting ATP testing, you're sampling sites at random. It's a bit of a speculative, perhaps understandably, it's speculative in where you actually test, and therefore the ATP test reading. So it may or may not be reflective of the wider environment. Light sources, as I say, they can screen large areas. You do have to consider the specification of the instrument that you're using. So commercially, you'll find that there's a broad range of light sources that you can purchase, and they'll range in price and they'll range in power. And you would have to consider what was right for the environment that you were examining. It will detect substances that don't contain ATP, and whether it's of interest to staff, as I say, we're conducting some work to find out actually what those substances are and whether there's any patterns within what we're finding. And there are limitations to the technology in terms of it won't work for all surfaces, and in terms of health and safety, which will depend on the instrument that you're actually using. Okay, so it didn't detect all traces that contained ATP. So there are substances that don't fluoresce that will still contain ATP, but it did detect a significant number that otherwise wouldn't have been detected. So where we got to in terms of conclusions is looking at maybe combining the techniques. So using the established methods of microbiological testing and ATP testing, but perhaps using fluorescence examination as an additional tool. And it's certainly where we're focusing further research, which Paul's going to be talking to you about. So I'll hand you back over to Paul.
Thank you, Sarah. And I think just to add to the presentation there, you know, in simple cleaning terms, I think we found that some of the cleaning techniques were really affected by the requirement for our cleaning staff to actually undertake physical effort. And examples of that were when we were looking at toilet cleaning. We found that the top of the toilet was clean, the seat was cleaned, but actually when we found that the cleaning staff have to actually show physical effort and bend down to actually clean the bottom of the basin to floor level, we found that there was higher levels of contamination found. And the same with bed cleaning. In regards to, we found that the top and the bottom of the mattress were clean, but actually the 6 inches that run around the outside of the mattress were actually still showing high levels of contamination. So, as Sarah said, there's a huge amount of work still ongoing from the first phases of the project back at the university, but we're now moving forward into a second phase of the project, and we're looking for an additional funding stream to actually support that work over the next 2 to 3 years. But what I really want to look at is every project needs an outcome. So what impact could this research have? I think, you know, first of all, it's around, you know, my first on the list is the national standards of cleaning. And could we actually move that from visual auditing to forensic auditing? And we're really lucky and gifted as we move into the second stage of this program to actually have Emma Brooks as the head of Soft FM for strategy and operations, who's actually going to come on board and actually join our stakeholder team to support some of that work on behalf of NHS England. Environmental cleaning strategies. I think I've just touched on, you know, 2 basic elements of cleaning where, you know, we found that fundamentally there was flaws within the cleaning techniques, which, you know, could affect the cleaning strategy. And I think, you know, that's something that we probably need to look at, not in silos, but on a national basis to actually kind of support some of that work around the national standards as well. Cleaning auditing, you know, I think it's very much related to the way we audit, and I think, you know, by being able to actually look at the invisible and make it visible, I think it just actually supports that effort in reducing hospital-acquired infection and making sure that our areas are safe and clean for our patients. I think this is a term that's always been used many times in regards to when is clean clean. And I think that's always going to be an ongoing question, but I think through the research work that we're doing at the present moment in regards to light sources and fluorescence, I think that question is actually starting to be answered. And we're seeing that, you know, it's not just around isolated elements with a room, but it's actually a number of different areas within the patient zone where we're not actually getting to the actual point where we're meeting what we should be calling clean is clean. I've mentioned improved patient safety, staff training. You know, for many years we've used gels and we've used powders and UV sources to actually train our staff. And in some ways, these have always been looked on as it's the police. But with this system, you can actually look at stuff in real time. So you can actually go back into an area. You can actually demonstrate, you know, where the cleaning techniques have not been achieved, And actually, we found that it was really well received because it was actual and not theoretical. Reduce costs for infection prevention, improve patient flow. And the last one on my list is around looking at the change from infection prevention to infection prediction. Wouldn't it be great if we can actually use a system that would actually allow us to prevent because we've predicted that there's going to be an issue there? And I think this is some of the work that the university also want to follow up outside of the forensic world. We're now engaging with our computer science department. We want to look at how we can actually link all that information and data that we gather in regards to infection prevention and environmental cleanliness and actually bring it into one. And hopefully we'll design a tool which will actually support, you know, the evidence that we've been kind of collating over the last 12 months and will be collating over the next couple of years in regards to this particular project. And by doing that, you know, we want to use AI to actually support infection prevention. And I think that's really key to actually, you know, our end goal, which is actually to look at zero tolerance in regards to healthcare acquired infection. Okay, I also want to thank Sarah personally for picking up this piece of work, because I do feel that, you know, it is beyond the norm of forensic science. And I think because of her enthusiasm and support with this project, it's actually given us a real link to actually say, this is exciting and this is something that we want to be involved in. So it's a great thank you, Sarah. Thank you very much for that. And I think the last slide, just as I am back to Paul, just gives our contact details if anybody wants to get in touch with us. Thank you very much. Thank you.
Excellent, guys. There's a few questions in there that that I'd like to pick up on. A lady called Abby Davis, Infection Prevention Control Team, doesn't say where they are, but how do you set the threshold levels when you're doing these tests? Anybody?
Sorry. Hello, everyone. I certainly couldn't answer that question on behalf of the health board, so I'm over to Paul, really. Sorry.
Yeah, I think it's something that we will learn from, and we'll certainly kind of interject into the next phases of this project. But it's been very much around with the ATP around setting that threshold of 50 RFUs in regards to, you know, at what point would something become harmful. And I think Sarah kind of articulated that within the presentation, if that answers the question.
We've got a lady called Deborah Davis from the Leicestershire Partnership. Do you need eye protection when you're using the light source?
That's a Sarah question.
Yeah, when you shine the light at a surface or a substance and it reflects back, what you want to do is to capture the fluorescence. So it's twofold there. One, you wouldn't see anything if you didn't have the safety glasses on. And two, absolutely, you'd need to protect your eyes from the light that's coming from the light source. I meant to say earlier, because one thing I'm commonly asked is about UV and the sort of health implications of it. The light source that we've talked about today isn't a UV light source. It's blue light that's coming from it. So it's about 450 nanometers. The reason that's selected is because it's a bit more specific to, say, body fluids, for instance, and it can be therefore more sensitive. But yeah, ultimately, going back to your question, yes, you would need to wear the accompanying safety glasses when you're using it. And yes.
Amanda Ford's been on. I'm guessing this is one for the next stage of your research. When do you envisage this being the mainstay of auditing for cleanliness in hospitals? And I'm guessing that is going to be in the next part of your project.
Yeah, very, very much so, Paul. I think that's what I was picking up there, and you know, it's great to have Emma involved from NHS England to actually support the work moving forward. Because for me, I do feel that we should be in a position where we start to look at forensic observation as part of the national standards.
Lucinda Smart from RKB, how can other trusts become involved with your research? Is there a way that they can do that?
Okay, hello. Paul and I are based in Stoke-on-Trent. We're a friendly team and we're absolutely open to collaboration. So if anybody that's on the call today, if you want to learn more about it, if you'd like to come and see those light sources in action, please get in touch with us. We genuinely mean that. We want this to be a collaborative effort moving forward.
And Christine Perez, how long did it, from Central London, how long did it take for the team to complete the ATP test of just one room, Sarah?
Well, the first one that we did, so we did one room, the first one in one day, but we literally took every fluorescent trace that we could find. And we did think, you know what, we're going to have to get a system here. But like anything, the more that you're actually doing something, the more efficient you become at it. So we were then able to do 2 rooms in one day. But this is exhaustive as well of these spaces. So clearly you could prioritise items if indeed you wanted to.
I think that just about covers all the questions that we've got at the moment. We will have a few more coming in, no doubt, between now and the recordings. Well, obviously the recording's going out tomorrow, so we'll probably have some more questions for you then. So any that we've not actually answered today, we will email, or we'll send them emails to you, Sarah and Paul, and then you can answer them by email if that's okay. Have you got any final comments to make?
No, I think the final comment, Paul, is just to thank everybody for attending the webinar today, because I do feel that the work which is being done through staffs is very much groundbreaking, and I think it's only just the start. And I think just picking up on one of the questions there, we want everybody to be engaged in this, because the more data we can get, the more information we can get, the better evidence we can produce. So our goal is very much, at the start it wasn't, but our goal is very much to make this a standard. It's just to really thank everybody for coming on board, because just looking at the numbers, I think it's absolutely fantastic that people have got such a great interest in this and the work that we're doing. So it's a great thank you. Thank you.
And final thoughts from you, Sarah?
Just to echo Paul's words, really, thank you ever so much for spending the time to join us today, and please get in touch if you'd like to know more about it.
Brilliant. Well, my thanks to both of you for your excellent presentations. Hopefully you guys that have been watching have taken something from the webinar. Any questions that we've not answered, as I mentioned, will be forwarded to Paul and Sarah, and they'll endeavour to answer them by email. And don't forget, if you'd like to watch the webinar again at your leisure, then it will be available on the website from tomorrow morning. All you've got to do is go to www.nolex.co.uk and click on the webinar banner. Thanks very much for joining us. Hope you have a great afternoon, and we'll see you again soon. Thanks, guys.